Okay, thank you, everybody. Thank you for bearing with us. I'm Dr. David Moffet in New South Wales in Australia, and it is just gone after midday. Our guest for tonight's advancemyce.com webinar presentation is Dr. Lee Weinstein, who is a retired pediatric dentist. Hey, Lee, thanks for joining us. And Lee's topic for tonight has disappeared off my screen here. I just had it. It's a primer on pediatric dentistry. So I think this is actually going to be part one. Is that correct, Lee? There's plenty more information. You can't summarize pediatric dentistry in 45 minutes. But you can give people a good taste of it. So, Lee, I'm going to throw the screen and the microphone over to you. If you'd like to start sharing your screen and bring up your presentation and begin your presentation, that would be great. Thank you.
All right, here we go. Let's see. I assume that it's on. If it's not, please let me know. But
it hasn't come up yet, Lee. Sorry, you'll have to go to your share screen button.
Okay, excuse me. Let's go back to share.
Back to Zoom.
Back to Zoom, and we will share. And now, is that working?
Not yet. It's hang on. No, you hit the green button in Zoom?
I did. Let's go back and try it one more time. Here we go. Here we go. Does that work?
There we go. And if you can make that 100% or press the play button, I think is the one you want.
The play button will work. That should work. There we go.
Perfect.
And now it's working.
We're cooking with gas. Off you go, Lee.
All right. Well, thanks. I appreciate all your help. I am a much better pediatric dentist than I am a computer whiz. I'm not even a computer anything. So I appreciate all the help. And unfortunately, my 3 children are living in different parts of the world or the States, and they're not here to be my IT people. So what we're basically going to do today is, David was right and Michael are right, that you can't really do a full primer in 45 minutes on pediatrics, but we can do part 1, 2, 3, and maybe 4. I happen to speak a little bit faster than most, so I'm going to start and just give you a little background on myself. My name obviously is Lee Weinstein. I'm a pediatric dentist here right now in Scottsdale, Arizona, retired and or sometimes just plain tired. And I've been practicing for over 40 years. And I think I got a handle on working with children. I've had 40 years of private practice experience. I've had 25 years in teaching experience, teaching both at a university and teaching at a dental school, and ran a general practice residency and specialized in the pediatric portion of that general practice residency. So I cut my teaching teeth on that. In 25 years, we've gone through a lot of residents, a lot of teaching, and a lot of changes in dentistry, as obviously we all know. So I'm going to assume that most of the people that are listening probably heard some of this at one point or another, and either don't do a lot of children or would like to do a lot of children, have some fun doing it. But here's your typical kid that says, "You've got to be kidding me. This is where you're taking me." And that is usually the attitude of a lot of little kids. So we're going to follow some rules and regulations and some information that will start us on this journey. And as we go through it, we'll get a little bit more information, and hopefully you'll be educated enough to at least come back to part 2, where we get into more nitty-gritty things. So we'll start by just going down with the educational objectives. And basically, in this program, we're going to describe what the problem is in the prevalence of dental disease in the children in the United States and across the world. And the World Health Organization has deemed this obviously now way behind the times, but they have decided that this is an important problem and that decay is a worldwide systemic problem that needs to be taken care of. I don't know where they were before. I will just give you my little political points here or there. I'm from back east. We have a tendency to be more, I guess, open. I did my training in Philadelphia at Temple University and St. Christopher's Hospital for Children. And I moved to New Jersey. I taught at Fairleigh Dickinson Dental School, moved to Long Island, taught at Long Island Jewish Hospital, had my practices there, moved to New York, from New York to Arizona, where I ran an office here. I also worked for a Medicaid insurance company for a while. I became the dental director for the state of Arizona Medicaid program for 3 years. I have worked for Delta Dental. I lecture, I consult, and I just keep moving along. So back to the objectives. Disease problems have been around for eons of time, and now they're just starting to recognize that actually overall dental health and medical health go together, which just amazes me. But moving on, we're going to know the definition of dental home. We're going to understand how to create awareness in the dental home. Knowing what it is and creating awareness are two different subjects. We're also going to describe the definition of dental neglect, which is prevalent throughout the world. And we'll decide and define the dental disability and explain Caries risk assessments as we go a little bit further. We're going to talk about eventually some anticipatory guidance, knowing the impact of decay and educational issues, medically necessary care, and discuss the benefits of fluoride and supplementation, especially now that this in the United States has become a new topic of discussion. And we're going to talk about how to examine some children and tune out the noise, and then maybe get into some legal aspects in failure to refer, which are major issues. And ironically, I had a conversation yesterday with a med mal lawyer, and talking about failure to refer can be a major problem, both in the medical world and in the dental world. So we'll just move on a little bit more. Some more of the objectives is really understand how to evaluate and treat the children, describe the reasons that you go to a pediatrician and a pediatric dentist, know some of the tricks of the trade and radiographs and things like that. And we'll discuss as we go further on the benefits of xylitol. All of this will be part 1, 2, 3, and 4. So just bear with me. I hope I make this fun and entertaining. This is the kid we get. You're taking me where? I could just see that kid on a daily basis. Obviously, that child has just had a chocolate donut and has now more chocolate on them and in them than swallowed. But we've got to handle this little child, and we're going to turn that into a smile, hopefully. Okay, so the dental problem in the United States and in the world altogether is really the prevalence of dental disease, which is epidemic. Now, some of these slides are a little bit older. I've just kept those later because some of the new research has changed those numbers a bit, but the points are still the same. The percentage of children between 5 and 19 years old with untreated disease and dental caries is 17.5%. That was years ago. It has gone up since. That is a huge population of children that are left being untreated. Now, they're untreated for many reasons. 1, because of finances. 2, because of low dental IQ. 3, not having access to dental care. And there's numerous reasons that go on and on and on. The percentage of children between 2 to 17 with a dental visit in the past year in 2013, obviously, 11 years ago, but that's 83%. It has gone down. COVID has changed our ways of thinking dramatically, and more people over the last few years have resisted and have not gone to the dentist as they should, whether they're adults or whether they're children. So the prevalence of visits is less than 83%. We were doing well, and this is in the United States. The world has gone down dramatically as well, and these numbers are reflecting what happens in the United States. But worldwide, percentage of children between 2 and 17 it was down in the 50s and 40s, if not lower. Approximately 23% of the children between 2 and 5 have had dental caries in primary teeth. That is an astounding number. That number has gone up. Diet and dietary changes have made great impacts. What we grew up with, I went to dental school in the 1800s, and we basically, probably in the 50s, had more awareness in the United States to the dental problems. And 2 of the major influencers, basically, if you say, speaking in today's terminology, that have created that demand to go to the dentist were basically most of the toothpaste companies. The toothpaste companies like Colgate or Crest, in the years ago in the 50s, look, Ma, no cavities, and getting to the dentist 2 times a year, or obviously every 6 months, that made a huge impact on the parents in the 50s and the 60s living that leave it to beaver type of lifestyle and saying, hey, we better get our kids to the dentist and get them on Crest or Ipana or Colgate or other toothpaste that were around. And that was a big boon to dentistry. Although the 6 months or the periodicity of 6 months is, I think, a made-up term. That was really to sell more toothpaste. It certainly helped by getting those kids back into the office. Now with COVID and today's millennial population, some feel that they know better than actually the clinicians. It falls upon either the pediatrician or a parent or a dentist like us to sit there and recognize that that is a problem, and how are we going to take care of that problem? What are we going to do to make sure that we get that number up? 23% of children between the ages of 2 to 5% have dental decay. That is a huge, huge number. And again, with people being cooped up in COVID, here, just take a cookie. The kids are home, they're running around. How do I get these kids quiet? Give them ice cream, do whatever you have to do to keep them quiet and keep them stable. Is just a nature of the beast. So that has changed dramatically, and that number of 23%, if you check more statistics, you will see that it has gone up and up and up. And now we have more problems than when we started. So how are we going to correct those problems is the major issue, and what do we do? And part of that, if we're looking at the dental caries experience, you can see, and this is in the United States, that there is a definite ethnic slant one way or the other. You can see who has a higher incidence: non-Hispanic whites, non-Hispanic blacks, Hispanic Asians. Those numbers are up and up and up. And the overall numbers are up. 2 to 5 years at 22 or 23%, 6 to 8 years with experience of decay, 55%. Untreated dental decay is from 2 to 5, 10%, 6 to 8, 20% if you're looking at my list. And again, back to ethnic. And you can use the ethnic rules and say, hey, the educational levels are lower perhaps, and the necessity of dentistry is not there, or the importance of dentistry. And if you take us in the United States over the last couple of years, people think that, you know, and you can watch the economy go up. The price of eggs goes up to, you know, $8 a dozen, or milk goes up. People have a limited amount of money that are going to spend. And basically people will say, well, if it's not broken and I don't have a problem, I guess I can skip it this time. So you look at some people who are either taking their kids or taking care of themselves. They'll take care of their dogs, their pets, but when it comes to themselves, you know, if the money is tight, they're going to skip. You're not going to go every 6 months. You might go once a year. You may only need to go once a year, but you and the treating dentist will make that decision and make the decision based basically on you and your child's mouth. We look at kids. I've got 3 girls. Each one of my kids is on a different regimen from going to the dentist. One goes 3 times a year, one goes 4 times a year, because she builds up and she brushes her teeth and she does what she's supposed to. Doesn't have decay, but we have some more plaque buildup. And the other one goes once a year because that's all she needs. Radiographs are the same thing. You don't need to go to the dentist every 6 months and get radiographs. You don't need full sets all the time, and you just need to take what's necessary when it's necessary. That's a topic that we'll get into in a little bit. But if we sit and look at some of this stuff, the prevalence is still there in the United States and across the world. Again, with COVID coming in, that has changed and rotated everything, and what we knew before is no longer there. And that has created a major problem. So again, this is a really basically a 4-part or a 3-part lecture. So we got to get the basics in first, which we're trying to do tonight. And then when we get into the other stuff, we can get into the more nitty-gritty things. But we'll just keep going as we go along. If you have any questions at any particular point in time, you can either send them to me at my email, and David will provide that, or we can get you more information. I'm gladly more than willing to talk to people at any particular point in time. And I love doing that. So this is one of my passions. So we're going to move on to the next slide, and we're going to get the definition of the dental home. This is what I'm going to read it, and this is what it says, and then we're going to pick it apart a little bit. The dental home is an ongoing relationship between the dentist and the patient, inclusive of all aspects of oral health care, delivered in a comprehensive, continuously accessible, coordinated, and family-centered way. The dental home should be established no later than 12 months at the age, and includes referral to the dental specialists when appropriate. So if we pick that all apart, we're basically saying and this is the definition from the American Academy of Pediatric Dentistry. It's also accepted by the American Academy of Pediatrics in Medicine and the World Health Organization. And we've all done research, and through school programs and things, we all understand that finding that dental home early is key. They've done statistically some statistic studies that have said if you put on a fluoride varnish, we'll get into fluoride in a little bit, but if you put a fluoride varnish on the teeth within the first couple of months that they get there, that will help reduce the chances of decay for probably 30%, which is a huge chunk to get rid of. And that's why it's essential. So when I tell my parents, wherever they are, if they're in the mall and I meet people, or I'm lecturing, or I'm talking to you people, I say, please come to me, not at 12 months, but I want you to come to me at 6 months. Most of them look at me and say, are you crazy? He doesn't even have any teeth yet. Please excuse me, I use a generic he. I use, it's just simpler that way. So I say, hey, yeah, I understand that he doesn't have any teeth yet. Let me educate you first. If I tell you what you need to do, and then you're prepared to do it, then we can follow through on treatments and make sure that your child is cavity free, or at least has a reduced risk of decay. Again, there's multiple factors, and it's diet, it's home care, it's dental habits, it's a whole bunch of things. Having the fluoride, not having the fluoride, forget the controversy, having that all in there. So we're sitting there going, okay, come to me at 6 months. If you're going to come to me at 6 months, I'm going to take that little baby and I'm going to put him on my lap, or we're going to do a knee to knee, and we'll get into all of that in a couple minutes. But we're going to look at that, and we're going to do that exam and say, hey, what is his diet like? Is he breastfeeding? Are you letting him sleep with him attached to the breast, and the lactic acid from the breast milk or regular milk is in there? Is he on formula? Is he going to bed with the bottle? Is the bottle just sitting there and it's pooling up? And as those teeth, like flowers, arise and pop up, you're getting that covered with all the again, the natural sugars, the lactic acid, and it's all causing decay. So back to the studies say as soon as those teeth come in, if we put a fluoride varnish on, again, on the first two teeth, then we're working on a program that will help make it a comprehensive program and continuously accessible, which means that you're going to come to us on a regular basis, which makes perfect sense. We're going to make sure that we do what we need to do. We're asking you to do what you need to do. Unfortunately, this is our message. This is our dental message. This is the American Academy of Pediatric Medicine's message. But that message gets lost in the pediatricians. I know they're busy, and I'm not blaming anybody. There is no blame. We have to take, everybody's got to take responsibility for what they do and when they do it and how they do it. But I, as the supposed, or dentist, we as the dental experts and the pediatricians are the first lines of defense. So it's now no longer acceptable for either a pediatric dentist, or we don't do this, but a general dentist, or even a pediatrician, or anybody in the medical field, to sit there and say, no, he doesn't need to get there until the age of 3. Well, by the time age of 3 comes, we've had 3 years or 2 years of teeth exposed to soda, juices, cookies, lack of home care. You've got 4 other kids. The last thing you're going to do is brush that kid's teeth. Or he doesn't like to do that. They come into the office. Oh my God, he doesn't like to do that. He hates going into, anybody touching him. All right, well, that's a problem. And you know what? You're the parent, so you're going to have to take some steps to say, hey, sorry, you need to go to bed when it's time to go to bed. You need to brush your teeth when we say it's time to brush your teeth. Does it have to be in the bathroom? No, it doesn't have to be in the bathroom. It can be in the bed. It can be on the floor. My little one, Sydney, unfortunately, we used to put on the floor. I had to pin her down for the first 2 weeks because she would be possessed. But eventually she acquiesced, and up to the age of 6 or so, I could say, Sid, get on the floor, I'm brushing your teeth, and she would be fine. And the bottom line is, the more times, statistically, the more times a child goes to the dentist, the more comfortable they are. I'll just use this as an example. Obviously, we all go to the doctor. I have my physical tomorrow. And if the doctor says you need to have another colonoscopy, which is not one of my favorite things in the world to do, I have accepted it because, 1, I know that it's necessary. Two, I happen to like my doctor. And even if it's a bad experience, it's a better bad experience because he has a good bedside manner and I like him and I walk in less stressed out than when I walk into a dental office. You walk into a dental office with a 3-year-old and I come back and I tell you that your child has 9 cavities and we have to do something about it, whether we do it, restore it here in the office, whether we use silver diamine fluoride, which we'll get into, or other preventative measures, or we have to sedate, oral sedation or IV sedation or hospitalization. That's stuff that we shouldn't ever have to do. But if we did have to do some of that stuff, that little kid who's 3, who's been coming to Dr. Bob or Dr. Lee or Dr. Joe or Jody or whoever she's going to, or he's going to, they're much more comfortable. You know, they may cry. And I say again to my parents, your child may kick, scream, holler, and be miserable. And that's fine, because I'd rather them kick, scream, holler, and be miserable with nothing to do than kick, scream, and be miserable with something to do. So let's work on that. So if we start with that dental home, and again, at the 6 months, I'm now educating you on diet. I'm talking about how to brush the teeth. We're talking about habits. My daughter just called me. My grandson is 3, and she lives in Nashville. And she said, Daddy, I need you to look at his tonsils because he sort of can't breathe, and he sort of has kissing tonsils, and I'm not sure what's happening. I'll be there next week, so I'm going to take a look at that. We're going to look at all that stuff. And the pediatrician does that, and they do a pretty decent job. But sometimes they just lack at saying, hey, you need to get to the dentist. They may say it, and if they do say it, that's great. That may not translate into the parent on how important it is to get. So again, both for a parent and for a child, we need continuous and we need accessible, coordinated family care to the dental world. So that dental home for an adult or for a child, no matter where you are in the world, is really essential. So what we try to do is we try to instill that. And when I do lectures with nursery schools, when I do lectures in elementary schools or to parental groups of PTAs or whatever it is, I sit and nail home that topic. So although this is probably stuff that you understand and probably stuff that you may do, it may be stuff that you're not aware of. So stop saying, don't bring your kid till 3. If you don't want to treat that child and they're little and you don't like kids, you don't say I don't make enough money, well, whatever your reasons are, that's fine. Then refer out, because the bottom line is you're giving that child a problem, or potentially a problem. Fortunately, my kids have been okay. Some of it is fluoride in the water, some of it is luck, some of it is diet, some of it is parental care. There's a whole bunch of factors that affect that, but nevertheless, we want to see whether we can get that going and really stabilize those kids. Around the world, obviously, in first world countries, it's easy, but if it's not important in England, no offense to the English, sometimes dentistry is not important, and that's fine. But it is. And the more we go on, and the more of today's world, you sit there and say, hey, there's a huge connection between oral health and physical and mental health. And it's not a surprise. We've been talking about this in the dental world for 100 years. And now all of a sudden the pediatricians and the AMA and some of the other organizations are out there and saying, hey, there's a connection between mental health, physical health, and oral health. You know, how many times do we talk about periodontal problems and having bacteria go down, swallowed into the heart and having heart issues, or having all kinds of other dietary issues. You have a mouthful of decay. How can that child learn how to add 1 and 1 if he's got a stomach ache or he's got a toothache or he's got a headache? He can't, or she can't. So we've got to try to do everything we can to make this important. Unfortunately, my little soapbox point for a minute is that I think the ADA could do a hell of a lot more for this. And I use my example all the time. I want to go take Claritin because that commercial on television is amazing. That jingle. I wish I took Farxiga. I don't know what the hell it is, but I wish I took it because I like the jingle on the commercial. Gee, I wish I could. We don't even do enough advertising to say, hey, dentistry is important. And the cost is can be exorbitant, obviously, if you let problems go. But the last thing you want to do is have a child who's sitting there in pain and you can't do anything to help them. So let's get in there. Let's start at 6 months. Let me educate. Let you guys educate. And if it's not what you want to do, that's fine. Send it on to the pediatric dentist who's more than willing to take care of that child. All right. As we move on, again, this concept was derived from the American Academy of Pediatrics, and that they had that in their definition of medical home, which is the pediatric primary health care is best delivered, excuse me, and supervised by qualified child health specialists, pediatricians specifically, but there are many physicians that will take care of children, from general practitioners to internal medicine and whatever. And it's been shown that healthcare provided to the patients in a medical home environment is substantially more effective and less costly in comparison to the emergency care. No one wants to go to the emergency room. No one wants to spend 17 hours in the emergency room. And a lot of prevention is simple stuff to do. But if it's not important to you, then you're just going to bypass it. If you don't have money for that, then you bypass that. If you have a child with a stomach ache, you're going to take them, and you can't fix that, and you can't get a hold of your pediatrician, because now every pediatrician says, if you have a problem, go to the emergency room. We were on call. You had a problem, you called me. You had my phone number. Today, there are fewer and fewer physicians and dentists that will give you out their number and say, call me. If you have a problem, go to the emergency room. All right, so I have a problem with that, but that's a different issue, and we can discuss that at any particular point in time. So moving on, it is obviously less costly. And the last thing you want to do, if you don't have insurance, and many people don't have insurance or can't afford that. So it goes back to the old adage, an ounce of, prevention is worth a pound of cure. Simple stuff. Yes, we all understand that, but we have to get that message articulated to the parents. All right, so research supports the efficacy of early professional care, as we said. We do, when we sit and see them in the pediatric world, whether it's in medicine or in dentistry, and the general dental world will look at it. And if you have some training in pediatrics, you're going to do a Caries risk assessment. What are the odds are? How is this child being brought up? What are the diets? We're going to do some anticipatory guidance. Gee, that's a crossbite that needs to be taken care of. This child has a lisp or has a pacifier habit with an open bite. Will it close? Will it not close? And we need periodic supervision. So for us, some kids are on with potential problems, could come every 2 months. Some people have spots, and I'll put on silver diamine fluoride. Again, we'll get onto that. And if you don't have that in your armamentarium in your office, you've got to be crazy not to. And that works for, and this is just my little plug right now, but that works for young children who I need to hold off before I can get into to do some type of sedation. It'll work for special needs. It works for the elderly who can't get out of the house or are in homes. It works for the seniors who say, listen, I want to get this work done, but I can't afford to get it done. I can't afford to do all 4 quadrants. So let me see if I can stabilize you for a little bit and get some time and buy some time out of that. So what we're doing early on at the 6 months, the 12 months, the year and a half, besides putting on that fluoride varnish and doing that. And now there are pediatricians that will start to do that because they're now getting paid for it, and they're jumping on the bandwagon, and they're saying, hey, the cost of the fluoride is 80 cents an application, and I make $27 on that. That's a good, I'm going to Las Vegas. They're my odds. If that's the reason they're doing it, that's horrible. But if that's the reason they're doing it and they're helping a child, I'll buy it. So we do all of this stuff. And as a dentist, if you're not comfortable with doing that, there are ways to increase your knowledge. I just edited a book that was printed in Germany, and I helped to edit the English version, which is a simple primer for kids, and it's basically called, just have to look it over, Dentistry for Children. Yuli Urich is her name, and I think they sell it at Quintessence. I get nothing out of anything. It's a great primer, so you can flip through that. It's easy to read. It's on 4th grade level. So it's simple for everybody. I had one in my office for the parents to read. I had one to show, and I'd given them to the pediatricians so they could look up if they see a spot and they don't know what it is, they can look it up. But we need to get in there for early prevention and early professional care. All right, the establishment of the dental home for children ensures a greater likelihood that they will receive the appropriate preventative care and routine oral health care, which is there. If you're there and you're in the system, we at least have a shot at it. If you're not in a system where someone tells you not to come until 3, like we said before, we have a problem, because now you've got 3 years of bad habits, perhaps, and you're going to have a child with all kinds of problems. And then what do we do? That's the last thing either the pediatric dentist wants to do, the general dentist wants to do. I want a kid that runs into the office, gets his prizes, smiles, may cry a little bit, but walks away and gives me a hug and says, "I love you, Dr. Lee, and thank you." That's what we want. So if you're in our system, you got a greater likelihood of having the appropriate care. And again, that starts at the pediatrician, that starts at the nursery school, that starts at the daycare. My wife runs a nursery school, and unfortunately, there's a lot that they can't do. But if they could wipe around the kids' teeth once a day, which they don't, which would be phenomenal, that would help. The more times you're in that baby's mouth with nothing to do, the better off. I tell a parent from day one, the day that baby popped out, after you finish feeding, take a washcloth, wipe around the gum pads, and get your hands in that mouth. That baby will get an understanding that seems to be normal. When you change the baby's diaper, that the baby at the beginning will squiggle and jump all over the place and fall off on the floor or whatever. You've got problems. And eventually, by the age of 2, that baby, you're changing the diaper. Okay, come on, Charlie, let's change your diaper. Okay, he sits there, he lays down, you change the diaper, and then he runs away. And he does his thing. So we've trained them. Sounds bad enough, but it's Pavlov's dogs. We've now trained them. If we train them early on and done a good job, they will be better off when it comes time to actually put a toothbrush into their mouth and say, "Hey, we're going to start doing that." They like the toothpaste. They don't care what you're doing, but get in there and start wiping around. That's early prevention. That is one of the routines that we do in healthcare that makes this child survive and thrive. Okay, so the AAPD recommends the dental home provides a comprehensive, continuously accessible, family-centered, coordinated, compassionate, culturally effective care for children as modeled by the AAP and their definition. It's basically the same definition. We just like to use big words, but the bottom line is get in there, make it comprehensive, do your risk assessment, and get in there and make sure that it's family-centered and coordinated, where the patients. My office used to be like Cheers. Everybody knew your name when you walked in. You want to go to an office where you feel comfortable, where there's compassion, where there's understanding of what's doing. You also need to understand the cultural aspects of your neighborhood and the upbringing of the population that's there. Some people think that, we have a hard time doing this, but some people say, "Hey, yeah, my great-grandmother lost her teeth at 30. My mother lost her teeth at 35. I'm losing my teeth and I'm going to be 34. I guess it's just natural that my kid will lose their teeth." Obviously, that's a silly response, and that's just an excuse. But starting early enough and making it effective care with the fluoride models and everything else that's there, and the materials that are out there, where now we can fill a little spot with a composite in 2 seconds with no anesthesia, maybe a little bit of nitrous oxide and whatever it is, and now we've taken care of a problem. Or we're going to take care of that little white spot on that kid that's all over the place, but I can put a silver diamond fluoride application on there once or twice, and it may turn it black, yes, but it'll arrest the decay. So at least we stabilize that kid till he's a little bit able or better able to sit in the chair. Comprehensive oral care, including acute care and preventative services, also go with the AAPD, our periodicity schedule. We want you every 6 months. We would rather you not go to the emergency room, because the emergency rooms they're not prepared. Unless the hospital has a dental clinic, and unless they have, where I taught at Long Island Jewish Schneider's Children's Hospital, all our residents rotated through the emergency room. So if there was a dental problem, whether it was kids or adults, they were able to handle it. The physicians are so overwhelmed with going through the residencies and doing their other stuff that the last thing they need to do is worry about, what do I do with this teeth? You got to go to the dentist. So follow the periodicity schedules. Go every 6 months. Stay away from the hospitals if you can. Sometimes you have no choice. But again, if your doctor is not on call and sends you to the emergency room, find another doctor. Sorry, that's my opinion. I know you need to have a life and it has to be a happy work balance, but I signed up for it. I work 6 days a week. You had my phone number. I got called, not a lot, because they knew they were comfortable enough, and either they waited or not, but that's what we do. That's what we're supposed to do. That's how we're supposed to do it, and show a little compassion. But The hospitals now take that kid, put him in a papoose board, sew up his lip, and now he's screaming, and now he's afraid to go back into any office. So that creates a problem to begin with. We need to go through comprehensive assessment of oral diseases and conditions, which means that we really have to look and understand what could happen, what does happen, what might happen, how it's happened, and what we might do to control some of that. The decay process is individualized. Just like here it says, individualized preventative dental health program based upon caries risk assessment and the periodontal disease risk assessment from the AAPD are essential. It will tell you where you think that child is headed. Is he a low caries risk assessment or is he a high caries risk assessment? How's his diet? How's his management? How's his home care? It's for infants, children's, adolescents, and it takes its case all the way through to adults. Because any general dentist that is sort of worth their weight in gold will sit there and say, hey, you have a high caries rate. You might drink 20 ounces of soda 4 times a day. You may have dietary problems. You may have diabetes. You may have other health problems. We need to control that. It's just like taking your blood pressure. I think that any general dentist that doesn't take blood pressure on almost every appointment is really being sort of lax. I'm sorry to say that. That's just my opinion. I think if we want to be respected, when you hear people say, I'm a doctor, and then you say you're a dentist, say, oh, you're just a dentist. And I have a problem with that. But if we want to act and be treated like physicians or physicians of the oral cavity, then we sort of need to act like that. And you know what? If you took me, I went to the doctor today, he took my blood pressure, and my blood pressure was 127 over 78. So it was fine today. But if it happened to go to 190 over 160, do not work on me today. That's it. You have adolescents. You don't know what these kids are taking or not taking. We need to go through a risk assessment. We need to look at it. We need to guide them appropriately, and we need to work together with our physicians to get the best care. So even though this is stuff that is not new to us, it's new to the medical world, I believe. So I think we need to sort of educate everybody all together. But if you're in the medical world and you get 6 months of dental information, you're really not equipped to handle that. And I use my example again. If I cut my face, I can go to a general surgeon who's very, very good, and he'll sew up my face and it'll look okay. Or I can go to a plastic surgeon who's trained in doing that and who loves doing that. Or I have a toothache and I don't want to do endo. I think I went into pedo so I didn't have to do a molar endo. But I'm going to send them to an endodontist who is good, who works well with kids. I send my patients to the appropriate referral to the patient or the doctor that I think is better suited for that child or for that adult or for that parent or whatever. So we need to get this caries risk assessment and really work together with the physicians. It's about time we started doing that and started acting like physicians. All right, anticipatory guidance is certainly essential in growth and development. And that's what we're doing at every appointment. And that's what you should be doing at every appointment. Are we a thumb habit? Are we a finger habit? Are we a nose picker? Are we, walking around with 2 fingers in the mouth? Do we have an anterior open bite? Do we have a cross bite? Do we have all kinds of growth issues that are there? Are the tonsils, like my grandson Charlie, huge, almost kissing? And if they're kissing, are they moving that tongue forward? And if they're moving that tongue forward, and he has allergies, is he doing postnasal drip and he can't breathe? And now today, you got more and more people doing sleep apnea problems because their tongue is moved forward and they can't breathe appropriately. We're looking at all of that stuff. And if you need an early anticipatory guidance referral, use your orthodontist. The orthodontist is more than happy to see little kids. They may not do anything, or they may. You send them to where you think it's appropriate to go. I know that if I sent my little ones to a certain person and he specialized in this, that they would come back, they would understand what they were doing, and they would appreciate the fact that they were there, that the doctor wasn't selling them an appliance that wasn't necessarily necessary at that particular point. But we need, as oral health care providers, adults or not, to sit there and go back and say, hey, what is our guidance with growth and development? How are we growing? What is this kid doing? And what can we do to get rid of the habits? Now, oftentimes I will say, listen, You've got a kid that has an anterior open bite, thumb sucker, has problems in school a little bit. I say, you stop that problem right now, he's going to have major problems later on. So I sit there and I'm facetious about it, but I'll say, would you rather spend $6,000 in orthodontic care or $60,000 in psychiatric therapy? I think let the kid, suck his thumb as long as we're watching it and we know where we go. If you stop that thumb habit by the age of 3, give or take, most of the teeth will drop back down. We're looking for spaces. We're looking for all the things that you learned probably in pediatric sessions of class, but forget it if you don't do a lot. And again, if you don't like doing it, that's fine. Refer out. The bottom line is it's a two-way street. You're referring that child out, that pediatric dentist has the opportunity to say, hey, I like Dr. X. He refers me his kids, but that's not why I like him. I like him because he does a good job. I understand that he understands that he's not qualified to do certain things, but he can do many children, and I'll gladly help him, but I'm going to send him the parents. So it's a paradigm shift. I think it's very funny, and this is just my political comment at this particular point, because we're running out of time, is that I don't know why pediatricians or pediatric dentists please beg the general dentist to send me their kids. Okay, fine. You want to send me a referral? Send me a referral. But chances are, if you've already ruined that kid, I have a major problem with that to begin with. So once that's done, that's a problem. So I think that the general practitioner should really be banging down the door on the pediatrician, on the pediatric dentist to say, hey, please send me your adults. But either way, we need to pay attention to what's there, and we need to make sure that we're guiding that growth and development issue appropriately. We have to plan for acute dental trauma. We have to train the parents and say what's happening. We get calls all the time. My kid fell on the ground and broke his front tooth. What do we do? How do we do it? What do we handle it? How do we handle it? If you don't know how to handle it, that's fine. Then refer it. The last thing you really want to do, unless you have to do that, is send them to the hospital for a problem. What do we do with that tooth that has been knocked out by the soccer player accidentally? Do we have the tooth? Do we have the chip? Can we put the chip back on? All of that stuff. It's just a matter of what you do with it. And that's what we're trained for, and that's what the pediatric dentists are trained for, and that's what you guys in the general population are trained for. You just don't see that much of it. And if you're not comfortable doing it, then again, refer out. But we need to know and plan, and we need to educate those parents. What do you do when your kid falls and has a problem? First thing, you're going to call me and tell me what it is. Now with FaceTime and with all the things that are out there, pictures, send me a picture. My daughter sent me a picture of Charlie's tooth with a tiny little chip on it, which was nothing. I said, okay, we can take care of that. But I said, don't worry about it. But here's what we need to do. Look for this and this and this and this. Information about proper care for the child, teeth and gingiva. This includes prevention, diagnosis, treatment and disease, and supporting and surrounding tissues in the maintenance of health, function, and aesthetics, and those structures in the tissues. Basically, we need to educate a parent, a child, when they're able and capable of doing that, and really we need to stay on top of that. We need to prevent, and we need to diagnose, and we need to treat appropriately. As we get into, we're running out of time. This will be the last slide. We're talking about dietary counseling. We do that for everybody. And the bottom line is, for everybody, we go over what are they eating, how are they eating it, when are they eating it. You know that if you eat sweets in conjunction with a meal, it breaks down differently than if you have a chocolate bar at 3 o'clock in the afternoon. If you want to go with naturally occurring sweeteners, then we can do naturally occurring sweeteners and stay away from sugar. All of this stuff. It's just a matter of now educating your parent. And what we do and I post weekly on my websites, and I post on 12 dental sites. If you look for me on any of these dental sites, I would say I post on all of these, and I put a lot of stuff on about diet and dietary counseling and what we should or shouldn't do. And I also post a lot on medical problems. I think this week's post is about the flu and vitamin C. So basically that gets us through. Let's see, we got one more. Okay. Yeah, we'll go back to that afterwards. Okay, so basically, I know I've sort of spoke a lot, and we just have to get the basics down first before we get into some more nitty-gritty stuff. So I hope you found this enjoyable. If anybody needs me, you can certainly get a hold of me. My email is D as in David, A as in Apple, F as in Frank, K as in Kenny, O as in Oscar @ AOL. It stands for Dental Associates for Kids Only. I'd be more than happy to talk to you. Send me a note, send me a question. I love meeting new people and I love helping people. I consult in offices, I do all kinds of stuff, and try to have fun. The bottom line is, if you don't have fun with what you do, then don't do it. So I guess that ends us for tonight. And I guess that we'll see you.
Hey, Lee. Hey, Dr. Lee. Thank you very much for that. That was great. I'm just going to unshare your screen if I can do that. Let me just see if I can do that. Where are you here? You've done it yourself? No, you've.
I got myself out of it.
You got yourself out of it on your screen. Let me just see.
Stop share.
There we go. That should do it. There we
go.
Oh,
perfect.
Excellent.
Good.
Well, thank you very much, Dr. Lee. I appreciate that first episode. Certainly our viewers, both online tonight and on the recording, will certainly appreciate the amount of energy and passion that you have for dentistry, even in your retirement and with your education as a retired pediatric dentist. You certainly have plenty of wisdom to share with the new graduates as well as the established graduates, because sometimes as a dentist, we just don't know when these things happen, what to do. And your logical approach to that has been excellent tonight. And we look forward to having you back next month for volume 2. So, and anybody else who wants to contact Lee privately, his email will be in the footnotes of this on the Advancemy website, where this broadcast will be uploaded so that you can watch it any time. And it's DAFCO, DAFKO @AOL.com. Thanks for explaining what it stands for, Lee. I was trying to work that out for many months as to what that actually stood for. So now I know. Now I'm much wiser. But appreciate your time, Lee. Thank you very much for that. And
all right, my little last plug. David, your programs are phenomenal. You are phenomenal. And if you people haven't listened to him, you got David and the rest of the groups that are there, you're missing a hell of a lot. So I appreciate what you do. I'm glad you appreciate what I do, but I learn a hell of a lot more than what I speak about. So you guys are great.
Thank you very much, Lee, and I hope everybody has a good night. I'm going to just end the recording now.
Happy holidays.